The American Association of Nurse Assessment Coordination, known as AANAC, and the American Health Information Management Association, known as AHIMA, have collaborated together to develop this presentation. We want to welcome you as you view how the ICD-10 CM and procedure codes tell a story about an individual's journey through the medical system. Mr. Jones lives at home with his wife. He is 75 years old and has traditional Medicare Part A and B insurance. He's in good health and takes an antihypertensive to control his blood pressure. The ICD-10 code I-10 for hypertension is noted on the screen. One day, Mr. Jones trips and falls over his cat in the kitchen. He is taken to the emergency room via ambulance where an X-ray is done. The X-ray indicates that he has a right intertrochanteric fracture of the femur, which becomes the principal diagnosis for his hospital encounter. For diagnosis coding purposes, notice the sixth character, bolded on the screen, is a 1, indicating that the injury was on the right side of his body. Hypertension is also carried over from his documented medical history. Additionally, notice that the ICD-10 system is useful in painting a more detailed picture of the patient's condition. While not mandatory, we've included the external causes for Mr. Jones's injury. These codes detailed that he slipped and fell over an animal in his kitchen. If included in the coding narrative, imagine how useful this will be for the therapist looking at home safety in the future. Well, Mr. Jones is admitted to the orthopedic unit later that day while he awaits surgery to repair his femur. His assigned diagnosis-related group, or DRG, length of stay will be 3 days, and his principal diagnosis is a displaced right intertrochanteric fracture of the femur. For coding purposes, notice the 7th character of the ICD-10 code, which is a letter A. This tells us that this is an initial encounter. Well, plans are for him to have an open reduction of an internal fracture the next morning. On day 2 of his hospital stay, Mr. Jones has surgery to repair his right hip and physical therapy is ordered. Notice the DRG is now changed to major joint replacement, indicating that Mr. Jones has had surgery. Also notice that the procedural coding system, or PCS code, has been added to his coding list. These codes tell the story of what type of surgery Mr. Jones had and the type of hardware they used to repair his broken hip. The record indicates replacement of the right hip joint using a ceramic synthetic substitute. It was cemented, and it was completed using an open approach. On day 3 after admission, Mr. Jones complains of shortness of breath. The nurse notes that he has coarse lung sounds, low pulse oxygen, jugular vein distension, confusion, and that he will not follow the directions of the physical therapist. So they order a heart echo, which is conducted and shows an ejection fraction of 35%, and his chest x-ray is positive for pleural effusion. The physician is contacted and orders are given to treat congestive heart failure and delirium. Additionally, his wife reported to the nurse that he becomes crabby if he doesn't get his 3 to 5 glasses of brandy each night. Queries are sent from the Clinical Documentation Improvement Specialist, known as a CDIS, for additional documentation specifications to support the appropriate ICD-10 CM codes. See our additional handout linked to this presentation for more information on obtaining CDIS queries in your facility. In response to the CDIS queries, additional diagnoses are added to the medical record. Notice that Mr. Jones has acute systolic congestive heart failure, pleural effusion, and alcohol dependence with withdrawal delirium. Since congestive heart failure and hypertension have an implied relationship, the ICD-10 is removed and replaced with I-11, which is hypertensive heart disease with heart failure. Additionally, the CDIS nurse reviewed the nutritional consultant's documentation, which added malnutrition and noted that the dietary supplement was ordered. A query is then sent to the attending physician to determine if he agrees with the diagnosis of malnutrition and to ask him to specify the type and acuity level. so the physician documented moderate protein-calorie malnutrition. The additional diagnosis changes the DRG to 469, which increases the length of stay to 5 days. On day 6 after admission and post-op day 5, Mr. Jones's delirium is improving. A discharge plan is developed to transition Mr. Jones to a skilled nursing facility to continue physical therapy. The final hospital discharge diagnoses and DRGs are displayed in front. Notice the principal diagnosis is the displaced intertrochanteric fracture of the right femur. The 7th character remains an A for the initial encounter. The hypertensive heart disease with heart failure, acute systolic congestive heart failure, and moderate protein calorie malnutrition is listed here as secondary. Also notice the additional codes that continue to follow Mr. Jones: alcohol dependence with withdrawal delirium and falling over an animal in the kitchen. By day 6 after admission, Mr. Jones is showing good improvement and is discharged to the skilled nursing facility. The admitting diagnosis to the skilled nursing facility is a displaced intertrochanteric fracture of the right femur. This changes the 7th character of the diagnosis code to a D, meaning subsequent encounter. Notice the additional diagnoses that have followed him from the hospital: hypertensive heart disease with heart failure, acute systolic congestive heart failure, alcohol dependence with withdrawal delirium, moderate protein calorie malnutrition. And we've also included that he fell on the same level from slipping, tripping, and stumbling over an animal, which notice has been reassigned to a subsequent encounter. This is indicated by the 7th digit changing from an A, initial encounter, to D, subsequent encounter. And finally, the location of the fall is included. Well, Mr. Jones becomes less talkative in the sniff. He tells the social worker that he would drink himself to sleep to deal with the loss he feels from the unexpected death of his eldest son a few months earlier. She encourages him to continue to share his feeling, and she makes a note in the chart to monitor his mood and his engagement with others. After a week in the nursing facility of monitoring his mood, the staff reports to the social worker that Mr. Jones continues to be less talkative and spends much of his time staring off at seemingly nothing. A consult is obtained for a psych evaluation, resulting in a new diagnosis, and an antidepressant is initiated. The nurse assessment coordinator reviewed the psych notes and updated the diagnosis list to add adjustment disorder with depressed mood. Well, within 2 weeks after admission to the nursing home, Mr. Jones becomes increasingly alert and oriented. He's engaged in therapy and he's conversing well with his wife. The transition back to home with home health is initiated by the nursing home's rounding physician. During the rounds, the physician indicated that Mr. Jones is no longer experiencing shortness of breath, jugular vein distension, and his acute congestive heart failure is resolved. His assessment results in some changes to his diagnosis list. His acute systolic congestive heart failure is resolved, and he's now diagnosed with chronic systolic congestive heart failure. His alcohol dependence with withdrawal delirium is resolved, and the diagnosis of adjustment disorder with depressed mood remains since he continues to receive an antidepressant. And he will continue to be monitored for stable mood as he transitions back to home. Lastly, the fall on same level with slipping, tripping, and stumbling subsequent encounter is moved to resolved, and the location of the fall in the kitchen is also resolved. Notice the list of diagnoses I've described on the slide. These are the diagnoses that will be included in the discharge recapitulation, which will be sent to the home health agency, the primary physician, and that will follow Mr. Jones as he discharges home. Mr. Jones returns home with a follow-up appointment scheduled with his primary care physician. His healthcare experience continues with the support of nurses and therapists serviced by the home health agency. Mr. Jones's experience in this medical crisis has been meaningful and impactful due to the attention of the nurses and the ICD-10 coding specialists who were able to tell the story through caring and sound clinical documentation, which was represented by the ICD-10 codes. We hope that through this presentation you gain insight into how diagnoses follow a patient through a health episode and the importance of clinical documentation improvement processes conducted by ICD-10 specialists. These specialists who accurately capture the diagnosis from the physicians involved. Just a reminder, be sure to download our CDIS handout linked to this presentation. And thanks for watching.